and I wanted to introduce our and bring our next panel up to the stage. They have to get mics, so I'll sort of do the introduction as they walk up there. Mark and folks, if you want to kind of walk up. But Paul already introduced Mark Hall briefly, but Mark is a law professor at Wake Forest University and a non-resident senior fellow with us at the USC-Brookings Schaeffer Initiative for Health Policy. And then we have Jessica Altman who's the commissioner of the insurance department in Pennsylvania. We have Jane Beyer, who is a senior health policy advisor in Washington State's insurance commissioner's office, and a state that is working very actively on legislation this session. Then we have Lauren Block, who is the program director for the health division at the National Governors Association. And then we have Mary Moody on the end, who is a health policy advisor for Senator Bill Cassidy, who obviously is working on this issue at the moment. And I will, well, I'm still getting mic'd up, but I will walk up the stage anyway.
You were very efficient with those introductions. Lauren, are you ready?
Yeah, I think so. I don't know. I was passed.
They have much more extensive resumes than that, I'm sure. Okay, great. All right, so we're going to just go down the panel. We're going to start with a sort of a broad overview of the variety of things states are doing. We're going to hear from two states that have been struggling with this issue for a while, and then we're going to hear from the federal government what's brewing there. So, Lauren?
Thanks, Mark. So again, I'm Lauren Block. I work for the National Governors Association Center for Best Practices. Just a little bit of context about why I'm here. So NGA actually has two parts. There is NGA advocacy, where the interests of governors are represented before the administration and Congress. And there's a lot of activity and a lot of interest right now among governors with regard to cost and value and controlling costs. In addition, there's the Center for Best Practices, and that is where I work. And we function as something between a think tank and a consultancy for states, really helping them learn from one another and identify best practices. States truly are the laboratory for innovation, as we've seen with surprise billing. It's really, the states are taking so much action right now, and we're seeing how the federal government is learning from some of what states have been doing in introducing new bills and considering discussion drafts. So that's really exciting. Our work has focused a lot in recent years on controlling costs in Medicaid, building more efficient Medicaid programs, working with high needs, high cost populations, using data to inform policy, and also addressing costs broadly with regard to pharmaceuticals. And currently we're seeing a lot going on in the private market with regard to surprise billing and a real growing interest. So I just wanted to briefly talk about some of the trends that we are seeing in states and where we think things might be going. So we've seen, just in the last few years, since 2017, at least 7 states have passed laws that address surprise billing. And we've seen many more bills introduced, and there are a lot right now, and some states are even beginning to think about changes to the existing laws that they have. I think where we know that everyone agrees is that this is a problem. Where there's a lot of variability is how different stakeholders view the problem and what they see as the solutions. So fundamentally, what's happening is that consumers, as Lauren mentioned, are having challenges where it's a situation they can't control. They're either going to the emergency room or they're going to an in-network provider and seeing an out-of-network, they're going to an in-network facility and seeing an out-of-network provider that they didn't expect. So really, I mean, what we're seeing in regard to state solutions in the trend is that really the states are moving more towards billing prohibitions, where providers just are not allowed to bill patients for the services. This is the biggest trend that we've been seeing, but it's been paired with other solutions. I should note that some states have laws that just address emergency rooms. Some address the providers in the in-network facilities, the providers who are out of network, and some of them are even more specific than that and only address specific provider types. Some say all providers, some say only specific provider types. Along with the billing prohibitions, we often see states setting reimbursement rates. Lauren did talk about this a bit. So we see everything from percentage of Medicare to the contracted or negotiated rates. Sometimes we also see a percent of billed charges. Lauren did reference Fair Health as one of those sources that's looked at. And then also we see greatest or least of multiple options. So sometimes there will be 3 different options presented, and it will be the greatest or least of those. And this is really where we've seen a big sticking point among states where when they've been trying to pass legislation, there's been a challenge. I think you'll hear a little bit more about that from my colleagues when they speak about their experiences. So sometimes what's used also is dispute resolution. And so that sometimes is paired with the billing prohibition. And it's where a state would set up an independent arbitration process. Sometimes the arbiters are given specific data points to look at. So there might be an all payers claims database. They might be given a reference point like Fair Health. In some cases, like New York and New Jersey, and this is a growing trend, there's baseball arbitration. I didn't know what this term was before, what it meant, but for those of you who don't know, it's when each party comes to the table with a number and the arbitrator is picking between those. So that has become more common. And then sometimes, again, they're given different reference points to consider along the way, so when they're making that decision. So that is a trend that we're seeing. If you can't come up with the reimbursement amount that everyone agrees to, that is an alternative solution. And oftentimes we've heard that it doesn't get all the way through the process. So things get resolved before you get to that, that arbitration process. There might be an informal process when it happens, but it can be a long process, and so they don't all get there. Another strategy that we sometimes see is a hold harmless provision. This is a situation really where the consumer doesn't have to pay the bill, but the issue is they may not know. You have to have an awareness for this to be relevant and helpful. So technically what is supposed to happen is the consumer would get the bill, talk to their insurer, and the insurer will pay it. Sometimes the insurer, as Lauren mentioned, would be paying the full amount. But there is that risk that the consumer doesn't know. It stresses them out. They're attempting to pay, and that can be a challenge. But there are a couple states where that is the policy in place. Another common thing that we see are disclosure requirements. These are oftentimes paired with some of the other strategies I've mentioned. There are at least 1 or 2 instances in states where there's disclosure, but there is not anything else. And so the issue there is you have a disclosure, you're being notified that you might be seeing a provider who's out of network, but what do you do? I mean, first of all, if you're in an emergency, this is not going to be very helpful. If you are finding out, like when you're checking in, that you're the assistant surgeon or the neonatologist or somebody else that you didn't know you were going to need in your procedure is out of network, what are you to do? And so there have been things going on where there's some bills that suggest upon stabilization you notify the person or at other times, but I think it's important to recognize that disclosure in and of itself, when you're in an emergency situation or can't have anticipated something, really probably won't be sufficient. So I did just want to also note, Lauren did talk about ground ambulance. This is certainly an issue. Most states have not regulated on this. It's often seen as a local issue, but it certainly is a problem where there are a lot of out-of-network bills. Also, when we talk a little bit, just briefly about the federal role, certainly we have seen air ambulance is a big problem across states. There are some states who have attempted to regulate, but because of the Airline Deregulation Act, states are preempted from taking action, and I think there is broad interest in a federal solution. Also, Lauren mentioned ERISA. This has been a challenge when it comes to self-funded plans and state regulation. There are a few states so far, New York and New Jersey, who have different types of opt-in provisions where either the plan or the enrolled individual can take action, but it's not fully protective. States can't require. So there's also an opportunity there federally. So that's sort of the playing field of what we're seeing. We've been excited and interested in what we've seen come federally in terms of discussion drafts and bills that have been introduced. I think states are interested in seeing what will happen, but there's also an interest in not being preempted and states being able to continue if they already have something in place that they like. But probably having a baseline would be something that many would appreciate.
All right, thank you. We'll call you Lauren with an A, distinguished from Lauren with an O. So, Jessica, Pennsylvania is never a dull place. How's this been playing out there?
Yeah, so, a couple of years ago, this issue really started coming to the department's attention from a number of sources all at once. It was sort of an overwhelming, we were hearing it from our own team of people who answers calls, assists with consumer complaints. We were hearing it from our legislature. We were hearing it from consumer organizations and other stakeholder groups. And so we began to focus on it really quite some time ago. One of the things that has always struck me about this issue is there's such a focus on these blockbuster, high dollar claims that get the headlines. And there's a reason for that, and those are really severe cases. But our experience has been there's sort of high frequency, low dollar versions of surprise bills and low frequency, high dollar versions of these surprise bills. So we have a state senator who is coming to us and has been a lead sponsor and avid supporter of the legislation all along because women in her district were seeking mammograms. And mammograms under both federal law and state law are supposed to be at no cost to the patient. But these women were going to a mammography center that was in network, and then somewhere a scan was sent to someone who wasn't even on site, to a radiologist who was out of network, and they were getting a bill that they never should have gotten. No, that wasn't a very expensive bill. It wasn't in the tens of thousands of dollars, but it was happening to a lot of women. The other case, and this is sort of on the other end of that spectrum, the one that really has sort of been stuck in my craw from the beginning was a gentleman who contacted us because he had needed heart surgery. He had gone to an in-network hospital, an in-network surgeon, but there was an assistant surgeon who happened to be out of network, who he had never met before the procedure, and he received a bill in the tens of thousands of dollars. The crazy thing about that case for us was he happens to live in the very northeast corner of Pennsylvania on the New York border. And he happened to work in New York, have insurance in New York, go to a hospital in New York, and have his procedure on the very day, I'm not making this up, that New York surprise balance billing protections went into place. And so he was protected by that law. And from our position, I think our response was, why should we have to be grateful that a Pennsylvanian is going to New York for their care to have this type of protection? And so we've been working on it ever since. It's been about 3 years of legislative sessions. I think one of the nice things about this issue, there are not very many nice things, but is that it's very bipartisan. There's nothing about this issue that is partisan. There's nothing about it that should be partisan. I think everyone is in this to find the right answer to help consumers and do it in a fair way. So generally the goal is take the consumer out of the middle and create a fair process for the insurer and the provider to agree on reimbursement. The first part of that is actually quite easy. Everybody agrees on that. This is a problem. Consumers are doing the right things and being stuck in the middle, really falling through a crack in our healthcare system that is not fair to them. The second part is the hard part, and figuring out how you determine reimbursement in a way that is fair, the right way to do it. And so in the couple of years that we've been working on legislation, I think Pennsylvania has discussed every single thing under the sun, from arbitration to Medicare rates to usual and customary rates to in-network rates to the Fair Health database, everything that is out there. I think I come at it with three sort of principles. The first is to always remember that this is inherently supposed to be a consumer protection bill and perhaps not a fundamental shift in how our healthcare system is supposed to work, although some may have bigger picture goals. And that means not just having a way for the consumer to take care of this if they do their homework and understand everything that's happening, but really keeping an eye out for the process, how the consumer will experience that process. Lauren, with an A, touched on sort of the differences between hold harmless and billing prohibitions and transparency. And I've been someone all along, I think Lauren got the line from me of, what is the consumer supposed to do? If you have a pre-scheduled surgery and you know your surgeon, and 2 days before you get a piece of paper that says, hey, by the way, your anesthesiologist may or may not be in network and you may or may not be on the hook for all of that cost, what are you supposed to do? Cancel your surgery? Is the hospital supposed to help you find a different anesthesiologist? Is the insurer supposed to help you find a different hospital? And so we have to create a process that is understandable and manageable for the consumer. The second principle is really not creating negative ripple effects in the market, trying to not disrupt the processes that we have in place, not creating, for example, there's a lot of discussion about disincentives for network participation. There are very good reasons why health plans have networks today, and we don't want to undermine that process. I think we also hear about potentially creating disincentives for physicians to practice in certain either types of facilities or even in Pennsylvania altogether if the process goes too far in the other way. And the third principle, which is really quite tied to the last one, is healthcare costs and trying not to do anything. We are all desperately looking for ways to move the needle on healthcare costs in a way that we are bringing them down, and we don't want to do something in this case where we take the costs that, according to Lauren with an O, are already really high and move them even higher because of the incentives that we're creating. So that's sort of the overall principles that I come to this with. In terms of where Pennsylvania is, because of sort of natural transitions in our legislative body, we have some new chairs, we have some new sponsors, and that's brought some really great new energy. Our House of our General Assembly has been holding hearings. Both chairs are lead sponsors of the Insurance Committee of that bill, and they're really going through an extensive deliberative process with stakeholders, and I'm hopeful that energy, as well as I think the attention coming from the federal level, so thank you for that as well, will help us get something across the finish line in Pennsylvania. But if not, we'll keep trying, and I'll see you back on a panel like this while we continue to work on it. So,
thank you, Jessica. So Jane, you've been through many decades of, or several decades of many different kinds of health policy issues. So how's this one striking you?
This one's interesting. So first of all, Commissioner Kreidler regrets that he was not able to be here today. So I wanted to say that. He has been, this is his 4th year trying to get surprise billing legislation through the legislature. And I think this year might be it. And I'm going to talk to you a little bit about the commissioner's thinking behind it, the issues that have come up, how we've evolved over the course of thinking about this now for 4 years, and a few issues that haven't been discussed that I think are really important to keep in mind. So I can say ditto to everything that Jessica said and Lauren with an A said. Lauren with an O made me feel guilty about some of the things that I'm about to say, but this is the real world of working in a state legislature where it is very democratic with a little d. And every opportunity for every stakeholder to clearly express their perspectives to legislators and others. So our legislation clearly has 3 major goals as we've gone into it. Prohibiting balance billing. We totally agree that it should not be the consumer's burden to have to figure out, oh, this is a right that I have, I guess I should exercise it. It's just when any of us looks at the bills that we get, given especially the trend toward higher deductible health plans and exclusive provider organizations, et cetera, it's hard enough to figure out what your appropriate cost sharing is, let alone whether something is actually a surprise bill. So it is not okay to ask consumers to have to figure that out. And in our bill, just as others have indicated, we're focusing on those situations where consumers don't have a choice. So emergency services, and then services provided by out-of-network providers in in-network facilities, ambulatory surgery facilities as well. Our legislation lists the type of providers that this would apply to. So radiologists, surgeons, ER docs, anesthesiologists, hospitalists, pathologists, and labs. And over again, the issue that we have tried to stress is trying to come up with a balance between provider and insurers' interests in all of this. And that's the hardest needle to thread. There's no question about it. And so with respect to payment standard, we tried for 3 years to have a formula in the legislation and got nowhere. And the breakthrough literally this year is we shamelessly stole from the state of New Hampshire, and the payment standard that's in our bill is commercially reasonable amount with a requirement, and I'll talk to you a little bit about how we're going to use our all-payer claims database, but essentially with a requirement that the insurer and the physician try to work it out. They have to have a 30-day period of informal negotiations before either can pursue arbitration. As Lauren with an A indicated, we're using baseball arbitration, and both parties have to split the cost of the arbitration. So there is unquestionably an incentive to not have to go to arbitration because it's expensive. So that's how we are addressing the question of the payment amount. We are one of the few states that has an all-payer claims database, and so our plan through this legislation is to develop a database that pulls information about claims in Washington state with respect to what the median in-network payments have been by insurers, what the median out-of-network payments have been, what the Medicare rate would be, and what the median bill charge would be. And the idea is to have the arbitrator have what would be thought of as the high end of what might be paid and the low end of Medicare. And each party is coming in with their final best offer, and the arbitrator has to choose one or the other. So that's how it's designed. I will say that if this bill is indeed enacted, and the chances are looking very good because the bill passed the House of Representatives with an 84-13 vote, and is scheduled to be voted out of the Senate Healthcare Committee next week. And again, the discussions have been completely bipartisan on this. But we have the opportunity through our all-payer claims database to monitor, once the bill is enacted, what is happening and what trends we're seeing in terms of out-of-network payment rates, and also what trends we're seeing in terms of network participation. So really, really quickly, in terms of a few other issues that I just wanted to point out. Emergency treatment received in border state hospitals. This has been a big issue for us. We have 2 consumers, one of whom received a $100,000 bill from a border state hospital for emergency services, and another who received a $200,000. And that's the surprise bill. That's over and above what was paid for the service. This is where federal legislation could be very, very helpful. The way we're approaching it in our bill is you can't just say to those consumers, too bad, so sad. So in our bill, we're saying where it's emergency services that are provided by an out-of-state hospital, the insurer does have to hold the consumer harmless from balance billing. But we would really like there to be a federal solution that says it doesn't matter where a hospital is for emergency services, you can't balance bill. Then enforcement. If we are prohibiting balance billing by providers, there needs to be a mechanism to enforce that. And our legislation gives the insurance department the opportunity to reach out to the provider and say, maybe you didn't know that this wasn't allowed, but it's not allowed, so do you want to take care of this and fix it? And if there is a repeated violation, the legislation in Washington state would make it unprofessional conduct for a provider to continue to balance bill where it's illegal, and also for facilities to do that. So that's the linkage that involves a good relationship with whatever your regulatory agency is that regulates providers. And finally, with respect to transparency, the legislation has requirements, carriers, providers, related to providing consumers information about what networks the providers participate in. It has the Office of the Insurance Commissioner developing a standard template, a notice for consumers to explain their rights. And Washington State is one of the states that is providing in the legislation an opt-in option for self-funded employer groups. And what we would anticipate is, for example, there are many Taft-Hartley plans that are self-funded. And so when those entities are going into collective bargaining, that's an opportunity for employees to come forward and say, we want these protections as well. So I'll stop there.
Wow. All right, impressive. So, Molly, we have ERISA preemption, we've got aviation preemption, we've got cross-border issues, obviously begging for some federal, or the Fed's going to sweep in and solve all this for us.
Well, working on it. So thank you so much for having me here today. I'm really pleased to be here to speak about some of the work that my boss, along with others, are doing in Congress to address this on a federal level, as it's been so clearly demonstrated that there's a need for. My boss is a physician. He's a gastroenterologist and represents the state of Louisiana in the U.S. Senate. So he, is attuned to some of the issues that patients have raised. And, I think others have mentioned how it just seems that this issue has reached this level of sort of salience, much in part, I think, due to the reporting that's gone on the issue, a lot of the activity on the state level. So it's given it this sort of great momentum that's enabled my boss to be sort of spearheading this effort in Senate together with 5 other members in Senate. It's equally bipartisan to provide a federal protection for patients from surprise medical billing. I think it's interesting to hear. I liked how you talked about the low incidence of high dollar bills and high incidence of low dollar bills. And when you contextualize that in the economic reality of most Americans, I know I've seen that 6 out of 10 U.S. families don't have more than $500 in a savings account. So when they get that, $200 bill, I mean, that's not just inconvenient. That's taking whatever it is, money to buy food for their family. And then when you get into those high dollar amounts, I mean, that's has the potential to be financially ruinous for that family. So I think that is sort of the driving force for my boss and others to be able to protect that that patient from what could be really devastating. So in terms of our process, we're not quite as far along as some of you all. We released a discussion draft last October in which we sort of had a mechanism of capping the provider charges and a greater of 2 methodology, so sort of a combination of a couple of things that have been mentioned. It elicited a lot of feedback from some of you in this room, and we appreciate that. And it's been highlighted in some reporting lately about sort of the level of acrimony between some of these stakeholders. And we hear from the providers about this is a function of narrow networks, of a growing trend of high deductible healthcare plans, of insurers not acting in good faith, and then from the plans we hear about some of these providers who might use it as their business plan to sort of stay out of network and balance bill. And then highlighting the really high level of charges by some of these folks. So there's certainly enough sort of blame and to go around between different parties. But we have taken this feedback and are trying to thread the needle on some of these issues. And there are the different frameworks that are being discussed. There's arbitration, there's capping provider charges, there's the bundling that Lauren with an O has talked about, there's network matching. That's sort of an iteration of that. So we're trying to weigh the pros and cons of each of these. I think they each come with their own set of strengths and weaknesses, and so we're still in the process of narrowing in on what our approach will be. I think sort of to echo some of the comments Jessica made, we're trying to keep a few things in mind, and that of knowing that this is not in terms of being a chronic balance biller. It does seem to be concentrated among a small number of, relatively speaking, a small number of providers. So how do you sort of target your approach to address what is, the bad actions committed by a few? And so, we're keeping that in mind, keeping in mind what undue implications there could be from some standard that we set. So, as particularly I feel the weightiness of that, knowing that we're putting in place a federal standard. So it's going to apply across the nation where there are different healthcare markets, where there may be different asymmetries. In some areas, the plans have greater sort of leverage over the providers. In other markets, the providers might have greater leverage over the plans. And so how do you sort of establish a federal standard that balances that and doesn't sort of tilt it in one way or the other? So we're keeping that in mind. And ultimately, we're certainly cognizant of the impact that this will have on costs and ultimately premiums, knowing that whatever we establish here can have downstream effects on that, which is really important. So at the heart of this, we know that it always comes back to protecting the patient. In this scenario, we could end up with a solution that everyone loves, and that would be so wonderful. We could end up with a solution that everyone hates, and that is, sometimes you might be doing the right thing if you're at a place where everyone hates it too. But we're keeping that patient in mind and knowing that that is the heart of this. And frankly, I think I'm optimistic knowing that this is an issue that the administration is interested in. The president held a roundtable at the beginning of the year in which he talked about surprise medical bills. We know there's interest across the Congress, in the House, and in the Senate. There have been different initiatives. And so ultimately, surprise medical bills, this is one issue where there does seem to be some momentum behind. I'm really encouraged to see the level of interest and engagement by stakeholders, by patients, by everyone. I think it's also part of a larger set of reforms that need to happen, getting at some of the, there's so many things we need to do in terms of looking at what is driving cost, what, how are our our incentives misaligned between different stakeholders that lead to increased costs. So we're thinking about all of these things broadly, and I think surprise medical billing fits in this picture, and I'm hopeful that it can sort of be the driving force to, if I'm honest, in Congress where there can be a lot of discord. This is an issue where there's bipartisan agreement that we need to do something. So I'm hopeful that surprise medical billing can sort of be the issue that can lead to agreements on other parts of our healthcare system, which also need addressing.
All right. End on a positive note. So I'm going to take just a few more minutes to pose a couple of questions, maybe just one or two to the panel before we go to audience Q&A. And direct your attention as panelists to the Brookings report. So I'll shift to Brookings rather than Lauren with an O because it's just confusing. So we'll call it the Brookings report, which I think pushes the boundaries a bit more because it tries to dig down to the root of the market failure that causes the problem as was presented, and brings more to the fore the role that the hospital plays in all of this. And so I think presents two pretty innovative ideas, and I want to get your reaction to them in terms of whether you would agree in principle. You can speak to the pragmatics, but also sort of does it make sense in principle, or do you see problems with this, either essentially requiring these key ancillary referral specialists to be, their services to be bundled with the hospital, so the hospital has to negotiate and bill for that on their behalf and contract. Or number two, set the cap, don't worry about setting the cap too low, because if you do set it too low, there's a market correction, which is the hospital can top off the payments to these ancillary specialists to bring it up to a level necessary to keep adequate supply. So those sort of two functions of the potential functions of the hospital, does that grab you as plausible or an exciting new idea, or we'll never get out of the gate? Laurie.
Sure, I can start, and I'll obviously defer to my state friends here to say what it would mean in their states. I mean, certainly, it would be beneficial to the consumer to have an assurance that whenever they go to a facility, they are not going to have an out-of-network experience. hands down, I think everyone can agree to that. I do think there's a question of the political palatability and whether or not states would be able to get the stakeholder buy-in to be able to make something like that happen. I think there's also a question of could there be some sort of cost shifting that ultimately does happen, and we need to think about that. I think just from an operational standpoint, and this isn't necessarily something that couldn't be overcome, but there is a jurisdictional issue. Most of the laws that exist right now are out of the departments that oversee health plans, as opposed to those that oversee facilities or the boards of medicine who oversee providers. So that would probably be a new role and a new level of coordination that might need to exist across the DOI, along with the facility oversight and the provider oversight. So.
So I agree with everything that Lauren said. I want to actually tease out that jurisdictional concern a little bit, because this is something that's coming up in a lot of areas as we talk about what to do about cost. And when you come to the state level, we are working within these existing regulatory frameworks where I regulate insurance companies. There's a long history of regulating finances and payments and sort of the financing side of the system. And then we have the state boards of medicine in Pennsylvania and our Department of State. We have facility regulation in Pennsylvania's Department of Health. And those functions for a very long time and still today are largely about public safety, largely about medical standards, largely really this health-related function. And there are not in most states entities that really oversee financing as it relates to the provider side of the healthcare system. And so I think from a pragmatic standpoint, but also certainly this gets to a political standpoint, when you're trying to fit a construct to fix this problem within the processes that we already have in the state, there isn't a natural home for something that would be overseeing how hospitals are being reimbursed, how hospitals are operating with independent physicians that practice or have privileges at their facilities. And so it becomes, there are serious operational challenges from a state oversight perspective. And it's also a bit of a mentality challenge in terms of the role states have historically played versus the role that some are looking for states to play in these broader conversations about cost. And I just think we should be cognizant of all of those dynamics.
So I would say a couple of things to be really concrete about what Jessica just said. States are purchasers, right? So our state Medicaid program covers almost 2 million people. And the legislature, without much difficulties years ago, oh my gosh, maybe even 10 years ago, passed a bill that basically said for purposes of the Medicaid program, because we are the purchaser, providers, out-of-network providers, have to accept the Medicaid rate. That's it. We're the purchaser. We're the 800-pound gorilla in the room. Taking that and translating that state as purchaser role into state as regulator role is challenging. The other issue is, there are two other issues. Political reality. Anything that has a state legislature setting rates is automatically very controversial and volatile. And even though we can say, but wait, it's only for surprise bills, the perception that others will have is camel's nose under the tent. So it's just a reality that we have to deal with all the time. And then I would respectfully say that I don't think that having the hospital bundle all the payment and having that be the entity that negotiates the rates with the insurance companies is separate from the market dynamics that we have around market concentration in hospital systems, especially in rural communities. So I think it's the classic example of if you squeeze the balloon in one place, it pops out in the other. I think those two are related, and I'm a little bit nervous of having that much more leverage in the hospital's negotiating position when they're negotiating with insurers, especially in states like Washington that have really strong network access standards.
Hasn't worked great for colonoscopies, I guess. So anyway, so any further comments, Mari?
Yes, I would just echo. I took some notes this morning. some of the concerns you expressed, and so far as, one thing as regards the bundling approach in particular, I think, on the face of it, from, on the consumer side, it sounds great. You've sort of eliminated the possibility of being treated by an out-of-network provider at an in-network facility, and that is a great messaging point. I think practically, there are concerns about what the downstream impact could be, in particular, the concentration of power, essentially. I think, my boss has concerns about, just generally speaking, the consolidation in our healthcare system right now, and that's among insurers, among health systems, the list goes on. But right now, even there was a health affairs piece which came out, which showed that the hospital facility fees have increased, was it 42% over the past 10 or so years? I might not be getting that exactly right. Whereas the physician fees have been around 20%. And so if you concentrate the negotiating power within the hospital, how could that further sort of solidify that trend when they're able to negotiate on behalf of all the physicians in their facility? And how could they leverage that essentially with the plan? And so that's my concern, is that could be used as sort of a driver to increase cost in that way. I think the providers would also come up with their own set of issues with that, insofar as just not having the ability to negotiate on their own behalf, and things like that I don't think is well received by them. So I would just echo some of those concerns and say that some also point to this is just really interventionalist within and could be very disruptive to the status quo. And so I sort of go back to that point I said in my initial comments about making sure our approach is sort of like proportional to the problem we're trying to address, insofar as this would have broad implications for the entire healthcare system and could get outside the scope of what we're trying to address here.
All right. Well, thanks for that reality check. Disruptive innovation at best. Anyway, so to the audience now, whoever has the mics, and we have a few minutes. I'll wait. You decide. There's a hand here, a hand there. How about over there? And the one in the back. All right.
So I'm Jack Hoadley from Georgetown University, and I appreciate all these comments. One of the things that I was interested in, several of you made reference to the scope of providers that might be included in these protections. And Jane, you in particular had a list of provider types. And I'm wondering about that, what limitation that creates. And one example I've heard about recently is plastic surgeons who might come in, somebody's had a facial injury, and that might not be on the list of providers. And so how do you think about sort of the consequences of limiting the categories of providers? And I think it's also relevant to the bundling question, because it's one thing to think of bundling for the anesthesiologist or the ER doc, but again, that doesn't necessarily extend to some of the other specialties, such as a plastic surgeon.
Yeah, I'll just say on the first point, on the second point, that the paper was careful to say we're addressing, principally just these hospital-based referral specialists and not the other kinds of physician-selected referrals.
It would be plastic surgeons.
Oh, right.
Would be.
They're not a network in emergency service.
Right.
Yeah. Oh, in emergencies, yes. True that. Okay. So it does get tricky. But other reactions to the sort of specificity of providers.
So I'll start, and then Jane can jump in since that's in there, Bill, which is my preference is not to have that specificity. I think as you sort of begin to collect the stories, which if you're in a role like mine, you are, I got to tell you, I bet if you ask 3 people on the street if they've had one of these, at least one of them will have, and you'll begin to hear the stories, right? And some of the specialties that we've come across were never named as sort of the common players when you first think about this. I think the one that really comes to mind, and one where we've seen some incredibly high bills, is neonatology. and out-of-network neonatology services following, in particular, premature births where there's no way to anticipate prior to giving birth whether you will need neonatology services or not. And then depending on how premature the birth is, the length for which your child will need those services can often be quite long. And then you get into that, what I said before, there's this focus on the high dollar claims, and they are worse. There's no question it is worse to get a $200,000 balance bill than a $200 balance bill. But to the point that you made about the savings and the impact, $200 is still $200 that fairly a consumer should not have to pay, and probably 100 other consumers shouldn't have to pay. And so, I, in my discussions, would strongly prefer to see a bill in Pennsylvania that really just says, this is a systemic problem that deserves a systemic solution and not limit it in that way. But now I turn to Jane to say why they have that in their bill.
No, I mean, Jack, your point is really well taken. It's really well taken. And I'm going to go back and say, should we think about, for example, adding neonatology? And then for those of us in the room, I worked for the state legislature for 20 years in addition to doing this in some other roles. And we frequently come back 2 years later, just like California is doing now and other states are doing, are saying, we need to perfect this. So your point's really well taken.
Can I just add also, I'm sorry, that labs are also, I know Jess talked about sometimes the low cost, but many of them, labs are another area where this is an issue, so it's not just the specific types of physicians.
Yeah. I'm going to move on because there are hands here, here, and there, and somebody gets to decide where the mic goes next.
Yes, good morning, David Kahn, J.P. Morgan. I think most everyone really gets the issue. I don't know if you accept the term cross-subsidization, but it seems like that's the common term to reference the disparity in payment rates. All of these solutions seem to have pretty significant implications for physician compensation. Has anyone actually done some numbers on what that would mean, and does that have any unintended adverse consequences?
I'm not aware of any really scoping it out to that extent. I would assume some of the specialist societies have taken a look at that, but whether it's public or not, I don't know. Next. Yep.
So actually this is...
All right, here. Yep.
Hi, I'm Christina. I'm a policy analyst with Capstone. I was wondering if you could comment a little bit more on the unique policy challenges to air ambulance. Yesterday in the GAO report, they highlighted a law in Minnesota that goes after a hold harmless provision for air ambulance, so more so at the payment from the plan perspective than to get around the ADA exemption. And then on the federal level, there's also just the appetite for doing something like that where you go after the ERISA approach as opposed to amending the ADA, because I know there are additional aviation challenges to the ADA perspective. So any comments you might, or more color you might have on that air ambulance situation?
I'm going to turn this to one person and one only. Who wants to?
Go ahead, Mary.
Okay, I would just say this has been of focus in Congress. Particularly last year during the FAA reauthorization, there was sort of a push to, there was some language that was considered that would enable states to use their regulatory authority to regulate air. It was not ultimately included in the bill. What came out of that was a task force, which is sort of supposed to be jointly done by Department of Transportation and CMS to look and advise on what would be the best path forward in terms of regulatory structure. As you can imagine, folks can get really nervous when you talk about amending the ADA in terms of just broadly, it might bring the airlines out, others, because if they think there's going to be changes to this. So I will say it's very complicated right now. I mean, there is some uniqueness to air insofar as it is, I think 30% of their transports are interstate. So that is, different than other types of services perhaps where it might reinforce the need for a look at it federally. I think the exact policy details of what the best solution is, I think it's something I'm looking into, but I'm not sure exactly what that is at this moment.
All right, in the back, probably our last question. So make it a good one.
Oh, great. Sorry. A lot of pressure.
Susan Zook, I'm with Mason Street Consulting, and I just wanted to sort of reiterate, I know we talked a little bit about the Medicare payment rates for a lot of these providers and that we don't have a lot of data. And as we see more and more people go into the Medicare program, taking more and more of that funding that might be set at what we consider a lower rate, is that concerning that we don't have a lot of understanding about whether or not that's an adequate payment rate and what that would be while we go into this rate setting discussion?
I'll chime in on that unless Lauren wants to know. Wants to take the last word? All right, yeah.
I mean, I would just say I think I agree. I think trying to get more data is helpful. It's not like we have no data. Like, we've looked at this for a lot. There was a lot of man hours spent trying to get these rates right. And I think, right, the key thing that we were kind of getting at earlier is if you set a low rate, you're not actually setting a rate in this situation, because the hospitals have a role here also, and they are going to be involved here. So, right, the next step on that is if you actually wanted to rate set here, and you actually wanted to say we really want to set the rates really low for anesthesiologists for whatever reason, you would need to not only cap the set of payment standard at 100% of Medicare, but you would also need to cap hospital payments at that point. Otherwise, you're not actually rate setting here. You're really just sort of letting the market dynamic stay at play here. So that's sort of the main thing is I don't think we really have, you're not really setting a rate at Medicare. You're setting a rate at whatever the market rate ends up being. It's just the hospitals now getting involved in this negotiation. But broadly to your question, I agree. I think it's worth looking more.
You're helping cost shifting to happen, and this time it's fixing a problem.
Yeah, well, I mean, right. I'm an economist type, so I don't believe any of the cost shifting rhetoric. Right? There's zero evidence that cost shifting is a thing. Why are that basis that relies on that hospitals are not profit maximizing now, or providers are not profit maximizing now, which seems a little bit silly. Trying to tell me that anesthesiologists aren't trying to get paid the most money they can now. But
I shouldn't say cost shifting just before our break. Sorry. Which it is break time. So to hear more on that, chat up Lauren. But anyway, 10 minutes, 8 minutes now because I took a minute and a half. So see you back at 5 after the hour.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.